Good evening, and welcome to the 38th Annual DeVos Medical Ethics Colloquy. My name is Dr. Amy Manderscheid, and I serve as the Acting Dean of the Kirchhoff College of Nursing at Grand Valley State University. Our college, along with the College of Health Professions and the College of Liberal Arts and Sciences, serve as your GVSU hosts of the Colloquy events. The topics covered in these important dialogues directly impact our interprofessional healthcare partners, those who are still students, and those who are actively serving our community. We are pleased to provide the platform to continue this prestigious event and to join in these discussions. If you're interested in receiving continuing education credits for this event, please be sure you follow the instructions provided at the registration table just outside the room. Special thanks to our Colloquy Planning Committee for their ongoing support and leadership of the DeVos Medical Ethics Colloquy. We would also like to recognize and thank this evening's major sponsors to include Corewell Health and Trinity Health. For the Q&A section of tonight's event, we will have individuals available with microphones to assist you in presenting your questions to our speakers. To give our opening remarks, I would like to introduce Dr. Paul Farr, our DeVos Colloquy Advisory Committee member. Dr. Farr is a retired gastroenterologist from Trinity Health St. Mary's and a community volunteer.
This is the 38th colloquy that we've had. It was started by these two individuals. Seated is Richard DeVos. It was his idea in 2004 to have a discussion of medical ethics. And so he asked Dr. Luis Tomatis, who's standing in this picture, to start implementing it. And the first one was in March of 2005. And every year, twice a year, except for COVID, we had to cancel one in March. We've had these colloquies. It's a pleasure to introduce the intellect behind the selection of speakers and really fine-tunes the topics, and that's a wonderful associate professor at Grand Valley named Jeffrey Burns.
Thank you, Paul. It's my pleasure today to introduce the moderator for tonight's event, Professor Andrew Spear, Professor and Chair of the Philosophy Department here at GVSU. Andrew has research interests in epistemology, that's the theory of knowledge, social epistemology, and areas of the philosophy of health. His recent publications focus on the epistemological aspects of gaslighting and on the political and epistemological implications of the work of Hannah Arendt. Professor Spear teaches courses covering the history of analytic philosophy, epistemology, and logic, as well as courses focused on knowledge, politics, and social media in digital cultures. Andrew?
All right. Good evening, everybody. I guess if Jeff is the intellect behind the event, I'm the good looks. Yeah. Thanks so much for being here this evening. It's my pleasure to introduce our two speakers for tonight, Chris Sidey-Gibbons and Dr. Alex John London. I looked up their curricula vitae ahead of time, their resumes, their CVs. I wanted to have a few citations to give, and I was going to print them out. So I hit print, then I went down to the end of the hall to wait. And eventually the printer just ran out of paper, okay? Which is to say we have two very accomplished researchers and scholars here this evening. Both of them, I went through two printers, two boxes of paper. I still couldn't get it all, so here we are. We'll make do. I'll introduce first Chris Sidey-Gibbons. Dr. Gibbons is an associate professor and chief section of patient-centered analytics at the MD Anderson Cancer Center in Texas. The goal of Dr. Gibbons' research is to improve patient outcomes by leveraging data science techniques to make better, more personalized decisions to guide patient care. Dr. Gibbons maintains links with the University of Cambridge as the Director of Health Assessment and Innovation at the Psychometrics Center and as the Health Director of the Concerto Platform. At MD Anderson, Dr. Gibbons is the founding director of the Institute for Data Science in Oncology Fellowship Program. And what I'll do here is I'll introduce Dr. Alex John London as well. Then we'll have them both take the stage for their Wait, no, I apologize. We'll have them take the stage one at a time. First, Chris Gibbons, and then Dr. Alex John London. So our second speaker this evening is going to be Dr. Alex John London. Dr. London is the K&L Gates Professor of Ethics and Computational Technologies, Director, so there's a comma, and Director of the Center for Ethics and Policy, and Chief Ethicist at the Block Center for Technology and Society at Carnegie Mellon University. An elected fellow of the Hastings Center, Professor London's work focuses on ethical and policy issues surrounding the development and deployment of novel technologies in medicine, biotechnology and artificial intelligence in particular, and methodological issues in theoretical and practical ethics, as well as on cross-national issues of justice and fairness. He is currently a member of the U.S. National Science Advisory Board for Biosecurity. That caught my attention. Okay, I wonder what conversations he's privy to there, and has served as an ethics expert in consultations with numerous national and international organizations, including U.S. National Institutes of Health, the World Health Organization, and the World Medical Association. So what we'll do is we will have both of our speakers give about a 30-minute presentation, and then we'll save Q&A for both of them. They'll come up together at that point to the stage for the Q&A at the end. So first, I'll invite Dr. Chris Gibbons to please come on up for his presentation. Please join me in welcoming him.
It's a real pleasure for me to be here talking tonight about what I think is one of the most exciting topics of our age, the ethics of how to leverage these powerful artificial intelligence technologies to best benefit patients around the world. Today, I'm going to start by talking about my perspective, how I came to learn how to use artificial intelligence and machine learning techniques, how I've been teaching them over the past decade or so. I'm going to give a working definition of machine learning and artificial intelligence that I think well serves our purpose here tonight of discussing ethical implications. And I'll talk about what I think are some of the key ethical risks and how we can engineer practically against them having negative impact for patients in the health service. So I was lucky to get a start in data science and artificial intelligence about 10 years ago when I was awarded an NIHR fellowship to work at the University of Cambridge on computational methods for patient assessments. I was lucky to work in two labs, one of which was leading the world really in the development of machine learning algorithms to predict individual behavior and personality from online digital footprints, and another that was world leading in assessing complex interventions in healthcare. Since that time, I've been teaching postdoctoral training courses on data science and artificial intelligence for social scientists. And I would say that I've looked over the shoulders of about 200 people as they develop their first ML and AI algorithms. And that's given me an interesting perspective, which I'll share with you tonight. Our lab has about 25 publications relating to the development of new algorithms to support clinical decision making. And we have experience in actually deploying and monitoring these algorithms at scale. And I have to say, my knowledge of ethics is really rather poor. So I come here tonight as something of an interested amateur, and I'm looking forward to the proceedings and my colleagues' talk following this one. So I've never really been comfortable describing my work as AI. AI, as you're all well aware, is often used as a hype term and is really heavily loaded. One of the big issues with it, I think, is that it's a sci-fi trope. And it's a sci-fi trope that never turns out well for humans. We lose control, and we're often subject to malevolent forces from a powerful being that we can't control. It doesn't set a good mindset for kind of sober evaluation and development of these powerful techniques. And it creates a difficult expectation bias, which can sometimes be useful for getting funding, but I think is not really useful for doing good science. Mark Malouf described AI as referring to whatever techniques hadn't been done yet. And in my recent conversations with ChatGPT, it actually quite eruditely described AI as the term, a moving target defined by the outermost boundaries of current technological achievements. And that's all well and good, but that makes it quite difficult to discuss the ethical implications of AI. If it's something that is continuously changing in its power and its scope and the way it works, then it's quite difficult to talk about the ethical implications. One definition that I've come to really like about AI, I was kind of inspired by Colloquy when he was speaking at the Cambridge University Student Union on a motion that AI was an existential threat. And he made the point that he didn't really care about what intelligence was or how it was defined or what artificial intelligence was. What he cared about was whether machines could become competent at particular tasks. And I think it's this task competence that gives us a nice framework to talk about machine learning and AI, perhaps divorced from the hype and possible existential threats. And machine learning and AI tools have massive amounts of task-specific competence developed over the past decade or so. I'm sure all of us benefit from the advantages that are within our smartphone daily. The ability to detect text, to look at images and decide what's in them, to help you navigate, and to drive cars and do language translation. In our lab, we focused on the application of these techniques for medical purposes and have focused lately on developing clinical decision support systems, helping patients understand which surgery might be best for them based on the outcomes that they would prefer to have in the future, or predicting things like patient mortality to guide end-of-life decision-making, or to highlight patients who are at risk of visits to the emergency department to perhaps change their care and intervene. And these models and these tools have been around for a long time. They've been used for at least, I would say, 20 years in healthcare. Good examples are the MSK risk recurrence nomograms and things like the Framingham heart risk score. They were previously based on the kind of linear statistical methods that we're probably all well familiar with. And since the availability of machine learning tools has increased over recent years, we have this possibility now to use bigger, different data sets and to model some of the more subtle nonlinear interactions that exist within our data. And we end up producing models that are ostensibly better than those previous linear statistical models. I think the big advantage we really have of these new machine learning methodologies is the ability to link up with that community, which has masses of funding from industry, as you're well aware. And they've really given us a new set of standards, new eyes to look at it and evaluate our technology. And they've given us new techniques for the development, the evaluation, and for the deployment of these tools. Now, one thing that I was particularly struck with when I sort of began to take up data science is that the explosion of machine learning and AI has come, I think, really from engineering schools, not from the statistical schools that previous kind of model development had come from. And one key difference that appealed to me was when you consider the development of a model, and most models take this as a very basic form. Data is input, a model is trained, and a decision is given. The statistical way of doing things is to look at the assumptions of of the model that we're using and try to make sure that our data meets those assumptions. If they do, we might consider that we've created a good model and we might use that model to make some inference about a large population. In machine learning, the subtle difference, although assumptions are still, of course, important, but the focus was much more on the performance of the algorithm against some sort of known ground truth. And what I noticed was that people in the engineering departments, they weren't bothered if things didn't work first, and they were happy to keep rejigging things as long as they could show that it was safe by evaluation. Then they'd created a good model. And it was quite an interesting distinction, and it's one that stuck with me and formed a lot of my thoughts, some of which I'll share with you throughout this talk. So today I'm going to talk about what I think are three important ethical issues that are facing machine learning and AI in medicine. The first is a lack of transparency around model performance and limitations, which can give us false confidence in the predictions and their use. The second is allowing ML and AI algorithms to learn biases that exist within our healthcare and health systems. And the use of those algorithms, therefore, may entrench those biases. And the third is a failure to bring models into practice in a kind of safe and timely way, which means that people who could benefit from the use of these algorithms today are probably not. And I choose these three issues because I think they're pretty prevalent. I think they're quite serious. And I do actually feel that with clever engineering, they're actually quite solvable as well. So today I'm going to talk about some solutions to these ethical issues that we've been working on. The first is the development of new community places and standards and training for performance. And we're doing that in collaboration with the National Cancer Institute and others. Particularly, I'm going to talk about the development of data sheets and model cards, which is these innovations that are coming into us from industry, and the importance of perpetual monitoring and predefined performance thresholds and rules and how they can be represented in data cards to improve the safety of the tools. I'll also talk a little bit about how I think we can stimulate demand-side drive for AI tools. I'll argue that a lot of the AI that we have available to us now is kind of supply-side driven. People built the algorithms because the data sets are available to build them, not because the doctors and physicians working on the front line were crying out for these problems to be solved. So I'll start by talking about some of the transparency issues in medical AI. So there are many, many studies that show really just how poor the literature in medicine is related to ML and AI. There is a lot of problems with most papers that are published. Kumar and colleagues publishing just this year delineated these issues into two baskets. They are emissions in reporting, people who publish a model and don't tell you honestly about its entire performance. And there are also some issues with model design that keep recropping up. And I'll talk about some specific issues there. The first, and this is something that I see all the time, is known as the accuracy paradox. Accuracy is a metric that we use in machine learning that explains overall how often your agent makes the correct decision when deciding on classification. It sounds like a really good metric to use, and most tools that allow you to develop a machine learning algorithm will kind of prioritize this metric while it's training. The model will learn to make decisions that maximize its accuracy threshold. But one of the issues that we see very often in medicine is that we have imbalanced data sets. That is, we are dealing with data sets where the things that we're trying to predict happen far less often than the counterfactual. And that causes an issue with accuracy. Because if we have only 5% of our cases that are interesting that we want to predict, then, well, many machine learning algorithms will just learn to say no all the time and never make a prediction of the positive class, and you'll end up with a 95% accuracy. Like I said, I've sat over the shoulder of 200 people developing algorithms. I've seen so many students and indeed professors who are learning this tool who will develop an algorithm who will get an accuracy of 95%, will stick their hands up in the air and celebrate. And then you look and see what the algorithm is actually doing, and it's just saying no to everything. And I was so surprised when I saw that this was actually coming out in our literature, and that researchers from prestigious schools publishing in prestigious journals were making the same errors. Some examples of some research predicting patient mortality using electronic health record data. Now, electronic health record data is typically not very information rich, I would say. It classifies, touch points with patients. It might give some information about what medications they're taking and their previous medical history. It doesn't give very granular information about changes in a patient's health day by day in a lot of cases. So I was surprised that the performance of these models appeared to be so good. The headlines were, our model can accurately identify those patients who are at risk of mortality within 180 or 90 days, and their accuracies varied somewhere around 0.90. Digging down into these papers, sometimes in the third or fourth supplementary appendix, and sometimes in another paper describing their performance, we see that the sensitivity of these algorithms was in fact really poor. I appear to have turned the computer off. There we go. Really poor. So 0.27 was their sensitivity. So although they appeared to have a strong accuracy, in reality, for every 100 patients who died in the prediction window, around 73 would be missed completely by the algorithm. This is just one example of many things that can kind of go wrong with machine learning. And one of the issues we were talking about just as we were having a snack before we came in here is the kind of pressure for people to publish, particularly at the early points of their career. And the desire really to not see the truth in the models that they're building. They see the accuracy number being high, and this has even happened to people who've come through our lab and demanded to publish even when we told them they were making similar mistakes like this. Another issue that happens fairly often is issues with external validation. Now, it is standard in our field to train an algorithm on one portion of data and then to take a separate portion of data and to do a kind of blinded experiment to see if the algorithm could predict that the outcomes in that case. And what I'm still seeing in the literature, and even at a conference that I was at a couple of weeks ago, is people don't do that. People are just assessing the model performance on the training data set. Now, machine learning algorithms are very good at modeling subtle nonlinear interactions, which means they're very good at overfitting to certain data sets. It's a very simple, it's almost a first day thing that you learn about these tools, but it's something, unfortunately, that is still being represented in the literature right now. Another issue that I see is static model development. And this is in a way incentivized by the way that we work in medicine and our research funding cycles. The research funding cycles that we have incentivize us to apply for funding, to win funding, to do some work, to develop a model, to publish, and then move on to the next grant. But what we're starting to realize more and more is that machine learning models are dynamic. And they change over time, and their performance needs to be monitored over time. We can't just develop it and publish it and put it out and then assume that that will continue to work. I think it's a little bit similar to buying a Ford truck 20 years ago. You bought that Ford truck and you took it home, and it would stay the same until you got rid of it. If you buy a Tesla or another electronic vehicle now, they're continuously updating and they change all the time. I think this is similar to machine learning algorithms. For people of a philosophical bent who are interested in more kind of existential unintended consequences of, and the third bias I'm going to talk about is unintended consequences. So machine learning systems can perpetuate biases and further harm disadvantaged groups. And this can often happen because of the inclusion of obvious proxies, which should be avoided. For example, the inclusion of race in a machine learning model allows a model to learn, various racial biases. But it can also learn those biases from obvious proxies, perhaps like a postcode or zip code. But as I say, machine learning algorithms are quite tricky, and they can find clever ways of learning biases, even if it exists in a system. An example from our research was years ago, we developed a system to assess whether somebody would be successful in a job interview using a recorded voice sample. What we didn't realize is that the algorithm learned to understand the register of the voice as a way of predicting whether the participant was male or female, and then based its decision largely on that. Even though we didn't tell the algorithm that this voice was from a man and this was from a woman, it still learned the bias. Similarly, in healthcare, you can imagine that there may be a part of your hospital where a certain group of people are not referred to because it's new or something. And then the data coming from instruments at that part of the hospital might also entrench that similar bias. Now, these are things that we probably can't know a priori. And it again shows the importance of us creating systems to evaluate to ensure that these things don't happen. So one of the solutions that I'm going to talk about is community standards. And it's really important for us to come up. So we're a community of people who are learning these tools anew. We are a group of people who are not necessarily taking computer science and machine learning in our graduate and postgraduate education, but coming through other tracks, such as through medicine, and then picking up these tools at a later date. And I think this is probably one of the key causes for the kind of errors that we're often seeing. So what we're doing, working with the National Cancer Institute and others, is to ensure that we can provide training and a community where people can gain critical insight into what they're doing. It's incredibly easy to teach yourself how to develop a machine learning algorithm. When I checked on YouTube this morning, there were 350 videos with the title, How to Develop an ML Algorithm. What's very difficult to do is to have critical insight into what you're doing if you're working on your own in a silo. So what we're trying to do, both with the NCI and at MD Anderson through the fellowship scheme, is give people critical insight such that they can understand the sort of mistakes they're likely to make and change them in the future. One incredible initiative I think that's being pushed to solve some of the issues that I've been talking about is model cards, originally proposed by researchers at Google AI. Now, these are dynamic cards that are designed to accompany algorithms that provide detailed information about how they were developed, what data sets we use, their intended purposes, their performance at different stages of deployment, and citations, etc. These are dynamically updated, and they're also developed, released prior to the model being developed. So they have standards that are set a priori before they're released. So one thing that's important to remember about machine learning models is that models and data coexist. And this is returning to the point that I mentioned earlier, that models will change over time and over place. Because models are completely reliant on data, and data is known to change over time, it's known to change place by place, it's known to change because of external shocks like the COVID pandemic, change the distributions of data that machine learning algorithms are exposed to. And data can also change when the things that produce data change. So if you have a scanner that now has a slightly different protocol, it might produce data in a slightly different way. So we need to be able to monitor how our models are working in time and in different place. And this is something that we've been working on quite recently. So here in this figure, we show a standard machine learning process. In the top part, we have the standard development process where we split our data into a training and a validation or a testing sample, and we ascertain the performance. Now, this is the static model that we might then publish in a journal and then continue to move on. But what we've been working on developing is a kind of dynamic method for assessing the performance of that model in perpetuity while it is making live predictions, and such that if it begins to make any mistakes or to treat a certain population differently, we can very quickly pick that up, make the changes, or perhaps sunset the model to prevent any harm occurring. So in our recent paper in Nature Communications Medicine describing this system, we're able to show that not only was this model very good at baseline and it treated different demographic groups rather fairly, but also by monitoring it over time, we could see that its performance did sometimes change. And this is work we did with colleagues at the Ellison Institute. And we came up with this notion of both leading and lagging indicators of model performance. Now, if you imagine that model performance, things like accuracy, requires a ground truth to be known, which is easy to do on a retrospective data set. It's very difficult to do when you're making live predictions, because if I'm predicting someone's mortality risk in 5 years' time today, it's going to be 5 years until I know the actual outcome. And in fact, if I'm creating a prediction that is meant to be attached to a implementation of a intervention, I hope that I can change that ground truth. I hope that my model is wrong. And this creates a real difficulty for analyzing model performance in real time, because we kind of want the models to be wrong. We want their positive prediction to be wrong because we want to intervene to change it. And even if it doesn't, it's going to be a long time before we know. This is a really hot topic of research right now. So some of the things we were looking at that we refer to as leading indicators, things that could give us ideas about the performance of the model today, are things like the prediction volume, the number of predictions that we were making every day. Are things like the data drift. We can analyze the distributions of the data that we're collecting day by day by day and compare those to the distributions of data in our training set. And we can also look at prediction drift, the sort of predictions that we're making daily. And if you look on the left-hand column here, we can see that there were 2 weeks where things were substantially different from other weeks. And what we found out was that some of our APIs that were connecting information from the health record to our algorithm had stopped working. So we were making far fewer predictions. The predictions we were making was on data that was quite substantially different. And what we were able to do is correct that quite quickly to engineer. And within 2 weeks, things had changed. It's a good example, I think, of just how and you might never have known this if you weren't monitoring this system, that like certain amounts of data weren't being transferred in quite the same way. And it shows really the imperative for assessing models in this way and over time. And we can see that in our data set, it didn't actually have a big impact on the lagging indicators shown on the right-hand columns because we were able to intervene rather quickly. Oh my goodness, sorry. This is really lost a lot of my slides. I don't know where they went. So I'm just going to conclude this last study that I showed and show that with careful handling and with savvy model building, we're able to use electronic health record data to properly predict whether someone had a risk of an emergency department visit. It's really important for us to monitor this data, to monitor these models over time. And in fact, by doing so, we're able to really understand how models are performing in deployment. And that by doing that, I think gives us the best chance for reducing the risks. I'll end my talk there.
Great. I appreciate the applause before the talk. We can go home quickly, make it early night. So there's going to be a lot of agreement with what I want to say and with what Chris was just saying. So I want to talk about structural challenges that medicine poses to trying to realize the promise of artificial intelligence. I'm going to focus my foil is going to be on something that is almost taken as analytic or as an axiom in the ethics of AI literature, which is that transparency and explainability are somehow necessary to the responsible use of artificial intelligence. And I'm going to argue that that's not the case. And I'm going to argue that, in fact, our focus on that is sort of taking away too much of the oxygen in the room, and that we need to be focused on other areas. And so I'll try to make good on this my heresy, right? So I'm an outlier in this literature. So I want to start, though, just by saying we have a duty to learn. There is a duty to learn in medicine, because our health systems have to meet important health needs. We have to try to reduce medical uncertainty to do that and reduce unwarranted variation in practice. There's a lot of medicine that's practiced because the person before that person taught that person how to do it, and there's not a strong evidence base that that's an effective or efficient way to improve outcomes for patients. And our healthcare systems need to function effectively, efficiently, and equitably. That's my book. You can buy it. My kids would appreciate that. They're about to go to college, but it's also free. So you can just go and download the PDF from Oxford University Press. And so, it's not a conflict. So here's the language of explainability in the literature. I'm not picking on this group in particular. They're sort of giving you the received view. So I'm just going to read you this long passage, but it's important. It has a lot in it. So they say healthcare offers one of the strongest arguments in favor of explainability, given the combination of devastating consequences of unacceptable results, the high risk of unquantified bias that is difficult to identify a priori, and the recognized potential for models to use inappropriate confounding variables. Explainability enables system verification. This improves the expert's ability to recognize system error, detect results based upon inappropriate reasoning, and identify the work required to remove bias. In addition, AI systems are trained using large numbers of examples and they detect patterns in data that are not accessible to humans. Interpretable systems may allow humans to extract this distilled knowledge in order to acquire new scientific insight. So if you think about that, that's a lot. Explainability, the idea of being able to interpret or explain a machine learning or an AI model. This is supposed to enable verification, help us recognize error, help us detect inappropriate reasoning, help us remove bias, and then also expand science, to help us to detect patterns where we're going to learn something new. So one interesting thing, just sort of as an aside, as somebody who lives and works among people who are, sort of at the top, of the machine learning field, there are people who think this way, and there are a whole bunch of other people then who are just engineers. They're just like, I just want to solve a problem. They don't have these kinds of ambitions. But that's a lot to get out of explainability. So here's my first general problem, my first concern for you. Explainability and interpretability are relationships between systems, AI models, and people. So they're a relationship between, do I understand this model and what it's doing? Do I understand how it takes inputs and turns it into some kind of output? The things that we care about, like accuracy, efficacy, clinical and social value, those are relationships between systems and the world. And therein, my friend, is the gap. And in medicine, just to sort of the preview, in medicine, very often the theories that we use to figure out what we're doing are wrong. And I will substantiate that claim in a minute. But that's the gap, and that's what's important. Explainability is a relationship between the human and the model. What we care about is how the model works in the world. So this focus on explainability and the idea that we can eliminate bias, we can do all this if we understand the model, blinds us to the real problems, I want to say, that occur elsewhere in the pipeline. So imagine now we're in one of these like old-timey, like we're shrinking you down and taking you into a cell. Well, so it's sort of that sort of fantastic journey, except now I'm going to shrink you down and take you into the pipeline, the life cycle of developing an artificial intelligence system. And then we'll see where problems arise, and then we'll ask ourselves, like, is interpretability or explainability going to be sufficient to help us avoid these problems? So this is the life cycle of, creating an AI system. First, you have to formulate a task. What's this system supposed to do for me? Then I better have data that will allow me to build a model that can perform that task. Then I have to test and validate that my model that I use the data to form the task actually does that task. And then I have to deploy the model, and we have to validate whether the model in actual practice works as well as we thought it would. So interpretability and explainability, those are all asking, do we understand how the model does the task? Whether a task advances a priority health need, that is a relationship between the AI system and health system capabilities and needs. And as I think Chris said, a lot of AI systems get built because data exists to build the system. Not necessarily because this is a priority health need and we need something to address this need. There's no guarantee the data you have, especially when it's routine clinical data, are going to support a model that's going to perform a task that's going to have this effect on health systems. You have to work really hard to have this effect on health systems. And you can work really hard and you can spend billions of dollars and not have this effect on health systems. Does anybody recognize the middle player here? So this is Ken Jennings, right? Current host of Jeopardy. Who's this guy? Thank you, right? Watson won Jeopardy. And then when Watson won Jeopardy, at the end of it, they were like, Watson, where are you going? And they're like, Watson's going to medical school. He's going to kill cancer. We're like, it's your turn, cancer. The Terminator's coming for us. It's coming for you now, cancer. And so it was like, woo, read this paper. I really encourage you to read this paper. It's from 2017. It's about cognitive computing, which was the term that we used back before we started calling everything AI. And, it said the goal of cognitive computing, which is what Watson was, is to create automated information technology systems capable of solving problems without requiring human assistance. That's the brass ring, my friends. These people were like, IBM was like, we're going to solve the biggest, hardest problem that we can. And when we do that, we're going to own medicine, which is a $3 trillion a year industry. So there's a lot of money. The scientists behind Watson, meanwhile, were saying doctors would be pretty delighted to have an AI librarian, something that would go out, synthesize all the literature that's about, this sort of, the volume of research that's being produced, especially in a place like oncology, where we no longer really understand tumors by where they occur in your body, but we understand them by genetic markers and what they express and, the life cycle of their growth and development, all these new things. Then the idea that if you had a system that would go out and find all the things that are relevant to this particular, tumor type, that would be really valuable. But instead they wanted this. Notice what the paper says here. New AI systems that augment the role of doctors and engage patients will. So what is that like? If you're in the stock market, they'll always tell you it's not enough to predict whether the direction and whether something's going to go up or down, but you also have to know when. And so it's like, well, will, like in the limit, like asymptotically, like at some point ever, or like now we have that ready to go, right? Will expand access, lower costs, and most importantly, improve outcomes. Those are all the things that we want, right? This is what they were promising. MD Anderson was a big partner with IBM Watson. They canceled the project in 2016. And this is before Chris joined MD Anderson. We talked about it. But after they spent $62 million on it. And so it's not clear that what that $62 million got them. It certainly wasn't part of this will expand access, lower costs, and improve care or outcomes. And if you say, well, where is Watson today? If you watch tennis, sometimes the statistics are given to you by Watson. This is all from the media, by the way. These are not my quotes. Watson was sold for scrap, they say, for about $1 billion, which to a guy like me, that's a lot of money, but they spent $5 billion on acquisitions to create the program. This isn't a garage thing. They had 7,000 employees working on Watson, and then it was called a total failure that they needed to cut their losses and move out on. This was no amount of explainability and understanding Watson's model would help you with this problem. The problem here occurred way upstream. It was a mismatch between system capability and the task that people decided that they wanted the system to perform. So this is about understanding our models and then making sure that the tasks that we ask them to do are going to unlock real value for our healthcare systems. The next then is the data that goes into our model and whether it's fit for purposes. Now, data reflect the purposes for which they were gathered. So that's like which variables that we measure, how often we measure them, the granularity with which we measure them. And a lot of medical data, especially if you're talking about data from the electronic medical record, is billing data. And so it reflects that purpose. And there are multiple confounding factors, including the effects of larger social structures and the operation of our healthcare systems that are in the data that we currently have available to us in health systems. So let me give you some examples. Drug development is increasingly analytic, and we're understanding both tumors and then the types of things that we're trying to intervene on tumors with at a genetic level. The vast majority of databases are populated by people of European descent. As of the publication of this paper, 3% of databases of the people in databases came from African ancestry. This is a paper by the folks from Google where they were trying to develop a deep learning system for differential diagnosis of skin diseases. So much to my mother's chagrin, I'm not that kind of doctor, so I don't know what the Fitzpatrick skin types are, so I looked them up, right? So this is type 1 all the way down to type 6. And then if you look over here, in the... so there's the development set, the validation set, and then the enrichment set. There was one person in the validation set who had Fitzpatrick type 6 skin. So what does that tell you? I mean, it tells you that the model is going to work much better on people, it's by the way, it's also not that much better there was nobody in the validation set for Fitzpatrick type 1 or type 6 either. So at the extremes, right, the model is going to work less well, or at least that's very likely to be the case. And this is common in these sorts of databases in terms of who's represented, because it's common in terms of who's included in our health systems, and our data comes from who gets included in our health systems. Then, even if you are represented in our health system, there's two kinds of ways in which a history of racism affects our data. So on the right, what you have here are measurements of blood oxygen levels in the arterial measurements compared to blood oxygen levels peripherally using the little thing they put on your finger that shines a green light on it. And what the graph on the right shows is that if your skin is darker, then the little thing on your finger systematically overestimates your blood oxygen levels. So if you come in and you're anoxic, right? You have dangerously low blood oxygen levels, and you're white. That's very likely to be detected, and you'll be given supplemental oxygen. If you're black, it's very likely that with the same oxygen level, you will be sent home. or at least a much higher probability. I shouldn't say very likely, a much higher probability. And then the data that had the inaccurate reading and then that had your bad outcome as a result is in the medical record. And then the question is that a feature of the patient and their biological state and the bad outcome? Or is that a feature of a bad health system that doesn't equally well minister to the needs of all of the people who rely on that health system? So features of our health system are systematically biased in this way. That's reflected in the data. And then sometimes when nothing is biased, we change the data. So spirometers are really clunky old plastic things you blow into to measure your lung volume. And for generations, we have applied a race correction to lung volumes. We assume that black patients will treat them as healthy with a lower lung volume than white patients. And we do this across medicine. That's what this paper is about. Race-based corrections that almost uniformly work out to the detriment of the populations receiving the correction. So all of that is to say that our systems, or the data that we have, reflect the way health systems work, and our health systems in this country work very unequally. When we educate new clinicians, we work very hard to try to extirpate histories of racial mythology. That, for instance, black patients have thicker skin, or they have a higher tolerance for pain, or all kinds of things like that. We try to extirpate this from medical education. But guess what? Large language models are trained on the internet. And what's the internet? It's just text from people, usually on Reddit. It's there, right? Recapitulating mythologies. And so these colleagues from Stanford go and they ask the large language model race-based mythological questions, and the models very frequently are like, oh yes, exactly. Let me tell you about the differences. So we can reintroduce now things that we've been trying hard to take out of medicine back in some of these systems because the data that they're trained on recapitulates some of these underlying dynamics. Even if race wasn't an issue and poverty and class and all these other things weren't an issue, there's a problem that AI doesn't look at the world the way that you and I do. So back when Twitter was Twitter and I was on it more like obsessively, I loved radiology Twitter. I'm not that kind of a doctor, but the radiology Twitter, they'd put up an x-ray and they'd be like, what do you see here? And I'd be like, what do I see here? And occasionally I'd be like, that shouldn't be there. Like, that's in the wrong place. And then you'd scroll down and they'd be like, there's a tube in the wrong place. And I'm like, yes, I got it. And then, they'd be like, I don't know. I have no idea what I see in this one. And I'd scroll down. I wouldn't understand the words that I was seeing. And, but the idea is you go, if you're a radiologist, you live in the basement with like big eyes. You just see hundreds and hundreds and hundreds and hundreds of radiographs. And what are you learning? You're learning to see structure and pathology, right? Structure and pathology over and over again. Okay, so the AI sees a matrix of zeros and ones that get created by very small changes in the gradation of the pixels on the image. That's all it sees. Everything has to be constructed from that. And it classifies these things on the basis of very sophisticated, statistical relationships between the zeros and the ones in that matrix. So that means if you have all your really sick patients stay in bed and the portable machine goes and x-rays them, and your healthier patients go down to the big machine, all the machine has to learn is the difference between, all the algorithm has to learn is the difference between between the main imaging device and the portable imaging device, and it's going to do really well now at catching less sick and more sick patients. And so there's been a bunch of studies about how image subregions contain features of indicative of a radiograph's origin, and other studies about the indicative of the patient's medical condition. And so there's a real question now. There's a huge amount of confounding. What would be perfectly fit? Data sets that would be perfectly fit for you and me aren't fit for the AI because the AI is privy to information that you and I don't see. All of this creates what are called data cascades. So I love this paper because I didn't write it, but I love it. Everyone wants to do the model work, not the data work. And so they say data cascades are compounding events causing negative downstream effects from data issues triggered by conventional AI or machine learning practices that undervalue data quality. And in this world, it's really true. Model work is considered very male and it's very mathematical. And so that's what everybody, that's got all the machismo. And data work is considered, low value, low quality. It's not a path to advancement. And so it's really undervalued. And so you get these problems now where when we train computer science students, the money all gets bid into hiring the best people, hiring the expertise, and there's not a lot of training on how to create a data pipeline, how to go and look and figure out actually who are the stakeholders who understand what's happening here, exactly what is the data that we would need to make sure we have in that pipeline, how do we curate the data that's in that pipeline so that it accurately reflects what's happening in the actual clinical practice. That stuff has to happen usually in the real world, but when we train our modelers, we're sort of being like, look, we got to train you on these very complicated computational techniques, so we're going to sort of give you the data and we're going to sort of set everything up for you. And that creates this environment now where you've got a mismatch in expectation. And then when you go out into the real world, and in medicine, we were just talking about how fax machines keep medicine alive. Right? Medicine keeps fax machines alive, but I guess it sort of goes the other way too, right? Like, it's not necessarily at the cutting edge. So the idea in terms of like data gathering, data curation, data pipelines. So a lot of work needs to happen there. And that's not necessarily the skill set that we've trained the people who are now bringing in the AI muscle with. So now we finally get to the model and understanding the model, and this is where interpretability and transparency are supposed to help us. And the part of the problem is now, you can't look at a model and be like, oh, the data from the, about lung volumes reflects these race corrections that we shouldn't have been doing. Like, that's already happened. That's already baked into your model. The light sensors for a pulse, the measuring pulse oxygenation, those are also biased, right? Well, that's baked into the data, it's baked into your model. So all these things have already happened by the time you get to the model and you're trying to understand your model and how it works. There are books out there that will tell you everything's a prediction. Don't listen to those people. AI systems are good at two things. Classification. Current generations AI systems are good at two things. Classification. That's like, is this a cat or a dog? Is this lesion cancerous or not? Those are real classification problems. And then prediction, where prediction is basically something like, if the world stayed the same and events I've seen before happened again, what would happen? That's a classical prediction problem. And insurance companies are in that business. Right? If you're admitted to the ward, given the characteristics you have, what's the probability you're going to die and how much is it going to cost us? And then we just keep running that kind of model. That's perfect. Medicine is interventional. If you came in and were just like, well, this person's here and they're really sick, I bet you they're going to die in a couple of days, right? And they're going to be really expensive. Then you'd be like, that's bad medicine, right? We want you to, now, given that you're here, we want to intervene on you, try to help you given that you're sick. Well, if you intervene in a way that you've already seen in the world, then yes, now you can predict what's going to happen. But if what you're trying to do is develop something new or optimize the care that you provide, and you're not just shifting back to something you did before, then that's not necessarily the kind of, well, you could still call it a prediction problem if you like, but you don't have data now you're going to have to borrow data from someplace else to be like, it's similar enough to this, and that's where things go wonky. So understanding how a system uses features to arrive at an output, that doesn't entail your ability to use that system for some other task that it wasn't trained for. And yet, here's Impact Pro. So this big expose that Obenmoyer and colleagues published about Impact Pro, where they were like, this is used in lots and lots of healthcare systems, systematically biased. But here's, as I understand it, here's what the problem was. The system was designed to predict, given that a patient is entered into the ward with a particular medical condition, what is the probable expense that is going to accrue to that patient? How expensive are they going to be? So you, as an insurance company, be like, that's something I'd want to know. Clinicians then said, well, what we want to do is intervene in the world, and so we want to intervene to help the sickest patients. So what if we took expense as proxy for sickest patient? And so we prioritized medical care to give it to the sickest patients. Now you have an untested, unvalidated assumption that sickest patients and most expensive patients are one and the same. And of course, they're not. In the United States, Black patients are admitted later in the disease course and have less insurance and less access to healthcare systems, and so they tend to be sicker than their white counterparts. And so as a result, if you used this system to prioritize care, you were systematically giving priority to less sick white patients over sicker Black patients because you weren't measuring sickness, you were measuring cost and sickness come apart. So what you had was a very complex statistical tool that sat on top of an untested, unvalidated assumption that was wrong. And then that created all this bias. But that's an instance of trying to use a system to do something other than what it was trained to do. And you can't do that in AI and assume that you're going to have the same kind of efficacy that the original system had when it was trained to do its very specific task. Okay, now what about, so this is now after, right? So prospective, real world, best alternative comparator testing. That's what you'd like to see, because once you create a model, you've got to validate it to see whether it's any good. So again, accuracy, efficacy, clinical value, social value, they're relationships between systems and the world. And when your model captures relevant causal parts of the world, then explanations derived from that model, they can help you detect and avoid error, they can improve reliability and efficacy, and they can obviate the need for clinical trials and empirical testing. We have this, ladies and gentlemen, in parts of the world like structural engineering. You can go onto the internet. There's a beautiful YouTube video that sort of does a graphic of like building the Charles Bridge in, I should know, but it's like 1220 or something like a long, long time ago, right? They didn't know all kinds of stuff. And structural engineers of today stand on the shoulders of those people. And so when we go to build bridges, and no one walks into a building like this and goes, I wonder how this thing stands up. You know, I wonder what kind of building this is. Like, that's really interesting. It's a new anatomy to this building. We don't go out and build many buildings and then see how many of them fall down anymore because we understand the underlying equations. We know soil composition, weather, climate, material tensile strength, structural capacities. We model your thing in a computer. And then if you ask me, well, what would happen if assuming I was a structural engineer, you'd ask me like, well, what happens if we made this arch longer? And I'll be like, look, I'll show you, it'll fall down, right? You know, or the blob in the middle, whatever. We know all the relevant counterfactuals because we know the underlying system. So that's beautiful. Explanations here do all the things that we want them to do. And if your training is as an engineer and you think that the rest of the world is as mature, the knowledge base in the rest of the world is as mature as engineering, then you would think explainability would be the right solution to the problem. Medicine is so far away from that, I just can't even start. Right? Most of the things we think in medicine are likely wrong. Mastectomy, for generations, we subjected women to this disfiguring treatment. Why? Because we had a theory that the more tissue you remove around a tumor, the less likely you're going to be, that recurrence is going to be. And then it turned out, once we compared it in a prospective clinical trial to lumpectomy, where you just remove the tumor and then a small periphery, of tissue around the tumor, there was no difference in terms of survival or recurrence. I think it was actually recurrence. I don't think we ran the trials all the way to survival, but, and so it turns out then this theory that had driven that was just wrong. And so for generations, we had subjected women to this disfiguring and invasive treatment, without actual evidence of its superiority. Now, and then peptic ulcer disease and lots of other things like that. But you could be like, well, those are all, like cherry-picked anecdotes. So I'm going to tell you about this because I think this is where people bet their money, right? Drug development is a huge place where people want to make money. You have like Ozempic. If you were like, had stock in Ozempic back in the day, like you're rich. So everybody wants to go and win. And you'll spend $1 billion to bring a drug to phase 3 trials. And 9 out of 10 things that they try, and they have the smartest people with the most complex models, and 9 out of 10 things they try don't work for anything. And that's generous because things like Latisse, do you know what I'm talking about? Have you ever seen a commercial for this? Latisse is a treatment for the crippling condition of anemic eyelashes or not sufficiently lush and long eyelashes, right? They invented this problem to sell you this drug. Now, no one set out to make Latisse. I think it was a glaucoma drug. And they went to look at the glaucoma patient's eyes and they were like, your glaucoma is no better, but your lashes, man, like, they are lovely. And they're like, well, we'll draw the target around, the arrow and we'll sell this drug. So the success rate includes things like that. In neurodegenerative disorders, nothing works. So my point here isn't to bash anything. It's just to say it's hard. Medicine is still in its infancy. And so you shouldn't trust necessarily your theory. And we don't allow you to be like, hey, I have a theory. Here's my drug. It's based on this theory. Let me sell it to people. We're like, no, what we want is to see it in an actual clinical trial. So when our knowledge of the underlying causal system is that incomplete, explainability, you can't rely on it to bridge the gap between model and the world. For that, you need to actually test the model in the world and validate it prospectively in the world. And so explainability isn't sufficient for responsible innovation. And instead, I think people have focused on it to the detriment of we need better prospective real-world validation of the models that we're creating. In medicine, proof of efficacy very often precedes our knowledge of how what we're using does what it does. You know that it works, but you don't know why it works. And aspirin is a really good example. For a century, we gave people aspirin and we said it will get rid of your pain. And if people said why, you might have said it's an analgesic, which just says, it's just another way of saying it gets rid of your pain. And if you were like, what's the mechanism? Then you'd have been like, I don't know. And if you figure it out, that's billions of dollars are on that. Because what we'd like is to tease apart the parts that get rid of your pain from the parts that give you the upset tummy and the parts that thin your blood. Lithium as a mood stabilizer, also 50 years, of use in psychiatric practice without understanding the underlying mechanism. And so if you said explainability is necessary for responsible clinical practice, then you couldn't have used these drugs. But it's not. What's necessary for responsible clinical practice is to be able to say, here's why I'm giving you the drug, here's the effect that we expect to see, and what's the evidence for that? Well, hopefully we've run some trial where we've controlled for confounders, because guess what? If headaches, the graph for a headache isn't this, right? Like, it's not like you got a headache on day one and then the headache never went away, right? It's just like you always had that headache. No, like headaches go like this and they go away. And so it's like, if you just don't do anything, your headache is gonna go away. And so we need to know, did your headache go away faster if we gave you this pill, right? Like, that's what we care about, not did your headache go away and we gave you the pill, right? That's always gonna be true. So responsible clinical practice for AI should be, well, what's the patient's clinical situation? Is the AI system indicated for this specific task? What is the warrant that we have for its safety, accuracy, and efficacy? And the warrant for this claim should be in the context of so that we should have the evidence for that should come from some sort of trial or prospective real-world validation. And then we want to know, what did the world look like when you validated that? And does the treatment that you're giving your patient, is the world look sufficiently similar that you can expect it to perform as well? And then, what are the risks and benefits? Those are the things that we would want to be able to tell our patient. None of that is an explanation of how our model goes from one set of inputs to a set of outputs. Yet this is very, very weak in medicine right now. When we talk about actual prospective testing, there are very few prospective trials of AI systems. We are awash in papers that are telling you they have validated an AI model, or that are telling you about their wonderful AI model for some clinical task, literally in the thousands. For one indication alone, COVID radiograph, papers that were saying we can detect COVID from a radiograph during COVID, there were thousands of those papers. There are very few prospective trials. Performance measures. So people like area under the operator receiver curve because it's a very generic measure. but there are lots and lots and lots of clinical cases where, so first of all, most clinicians don't use that as a measure of efficacy. They don't, of accuracy. And they probably don't care about that whole area. There might be a very specific point on that they care about. And many of these studies have high risk of bias. And this just goes throughout, in this systematic review of the COVID radiographs, right, in their current reported form, none of these models, and there were 2,200 in the initial sample, and then when they got it down, they looked at a few hundred. None of those models were likely candidates for clinical translation, even though some of these models were being used in the clinic already. You can go and look at the FDA, which I think will admit it is sort of been behind the curve and is trying to play catch up. But, in this review, again, from colleagues at Stanford, none of the 54 high-risk devices were evaluated by prospective studies, and among the 130 devices that they analyzed, 93 didn't have publicly reported multi-site assessment included as part of the evaluation. And so, this means you could develop and deploy a system in one health system and then get FDA approval with the prospect that you are then going to use it in a completely different health system with completely different practices and completely different patient population. It's very unlikely you're going to see the same performance across those cases. There's a ton of spin, so I'm not going to belabor a bunch of these, right? But lots of people, you'll read the paper and it's like we're ready to go into the clinic. But then when you go and you look at it, the research is very underdeveloped. There's poor reporting, and I'm just going to flip through, there's many of these systematic reviews, and the difference is shocking, is jarring. You go and read the individual papers, and the papers are no paper is like, yeah, we did a shoddy job, right? All the papers are like, our model is super great, it beats human performance, it's right, many of them, at least, 7% of them or so will say, we're ready to go into the clinic, and then when you have people sit down and do a systematic review, right, very few, I think a second systematic review of the COVID radiograph work was there are about a dozen that were mature and well done. So the default should be that internal validation is just not sufficient. We need clear markers of maturity. So we dealt with this problem in science when it was you'd see seed headlines, it was like cure for Parkinson's disease or something like that. And you're like, oh my God, finally. And then you read the paper and it's like reporting you some preclinical result or some mouse study. And so now we require that it say mouse study right up front, in mice or something like that. And so we need something like that. We need in AI, we need to have reports where it's this is a proof of concept study. Right? We need degrees of maturity so that you can tell what's the equivalent of a phase 1, phase 2, phase 3. So what's a proof of concept study? What's something that's more mature? What's something that has a robust set of evidence and that has real world evidence behind it? Because the proliferation of poor quality, reduplication of effort, it undermines the goal that we set out for in the beginning of trying to have efficient use of resources to make health systems learn better so that they can be more effective, more efficient, and more equitable. The kind of reduplication, scattershot effort where there's not clear momentum building of learning and the development of sound scientific practices that are making sure the ratchet is always moving us towards better, don't achieve that goal. The last thing is, if I can use a football metaphor, getting the ball to the 20-yard line, there's no medal for our team got the ball to the 20-yard line more than any other team. People would be like, well, then why does your team suck? If they didn't get it all the way through and get the touchdown, isn't that the main thing, right? And so building a model, you can have the most beautiful model in the world, but if you can't deploy it in actual practice and then maintain it, and maintenance no one likes to do. I mean, have you ever had problems with just the maintenance of your computer, your lowly desktop computer, right? AI is that, but just bigger and more complex. Okay, I'll skip that. So this is, this chart, so 0 on this chart is the first COVID-19 case. And each of these lines is the proportion of patients that would generate per day a sepsis alert. So sepsis is a dysregulated host response. So we think it's one of those things where we're not really sure exactly what it is. It's a blood infection that then the body is like, oh my God, I have this infection. I'm going to fight it so aggressively that I'm going to attack my own organs. And so it's billions of dollars a year in expense. Many people die from sepsis. So we want to find it early and intervene. And so lots of people are trying to develop a sepsis detection or sepsis alerting system. Another famous example where Epic had developed one and deployed it, and then subsequent studies found out that it wasn't that good. But so here's day 0, and then what happens? So this world, there's no COVID, and then in this world, it's like, well, you have sepsis, you have sepsis, you have sepsis. Look under your chair. Everybody has sepsis. And of course, like, it does that because of what we would call distribution shift, right? Namely, like the properties that patients have in this part of the world is just different from the properties that patients have in this part of the world. And so the red line is where you started to see people like Michigan. So this is where Michigan basically took its sepsis alerting system offline because it was like, it's noise. We're not going to believe it. I don't think I have a rash of patients here who have sepsis. I think I have a new disease in my ward. So what do you do now? It's not like sepsis has gone away. It's not like, well, we have COVID now, not sepsis, right? Like, you still have patients who are going to be septic. You still have to try to deal with that. And the same thing happened to, not in health, but American Express. I think it was American Express. They have a machine learning based fraud detection system. And, it's like when COVID happened, it was like, maybe you would shop on Amazon once a week. And now you have like 4 orders a day. And it's like, that's fraud. And you're like, no, it's not fraud. It's the new normal. Like, get ready. I'm going to be ordering from Amazon every day, like, every 10 minutes, right? Or I'm buying things from Home Depot that I wouldn't normally buy there, right? And it's like, that's fraud. And it's like, it's not fraud. So the problem is the world changes and these systems have to change. And so you have to be able to either retool them in real time or have an alternative. And that's part of responsible deployment. So we need better normative guidance in this space. We need normative guidance that helps us focus on the clinical goals that we want to achieve, and then making sure that we can complete this life cycle in a way that maximizes the probability that we're going to have interventions that work, that are based on evidence, and that make patients safer and healthier. And to do that, we have to have a more robust system of accountability. So this is like the little tour I took you on. These are some of the requirements I was talking about. But then our health systems, and this really comes down to like the most senior leadership at the health system, they've got to have a process in place for accountability. So like, whose job is it to do these various things? Those roles and responsibilities at every stage, they have to be allocated. There need to be procedures in place for sort of measuring whether those obligations were discharged. And then there needs to be, because this isn't all done by one person or a small group. This is a very complex process. And so you've got to make sure that relevant duties and obligations are all, codified, allocated with metrics for did you do your job? And at the end of the day, then, it's got to be the most senior leadership who are accountable for making sure that this is in place. So I think there are these major structural problems in the relationship between AI and the development of AI to try to make health systems better. Addressing these issues is going to require that we change the way we carry out medicine and the way we gather data and the way we store data. So I think the myth of cheap learning, that we're going to be able to bolt on machine learning onto current healthcare systems in order to learn things, that was really good at sort of, generating and ginning up excitement, but it's just not going to be a recipe for success. And I think interpretability and explainability, I want us to get medicine to the point that structural engineering is at as much as anybody else. People call that precision medicine. I want us to be there. I want it to be a reality just like everybody else. But until then, much less weight needs to be put on explainability and interpretability, and much more weight needs to be put on showing credible prospective evidence that your system does what it does in a way that's going to actually make patients better off than the next best alternative for doing that thing for them. Thanks very much.
All right. Thank you to both of you for these really interesting, stimulating talks. And I believe you both have microphones with you at the table there. I think you can just turn those on and be ready and we have plenty of time for Q&A, I thought that as you get yourself settled there, I thought I might just do two things, and I'll just launch one question to kind of both of you. So first, just by way of examples you've covered, I think we have covered a couple different sorts of examples that we might use AI in the context of drug development and testing as an example. We might use it for care referral, which is a little bit different kind of example, but should this person be referred for more care? To determine whether somebody's going to die in the next 180 days. I hope that one doesn't get a hold of me, but there's I'm just kind of repeating a couple of those examples also for the sake of everyone here. And then also maybe diagnostics of sort of image identification. This one's pathological, this one's not. I understand they're pretty good at that. But in any case, so there's just some of the examples we had. The question I wanted to throw your way to get things started, Chris, you talked about transparency, and Alex, you talked about explainability. And those maybe sound pretty similar, but I wonder if either of you might address, are those necessarily the same thing, especially in the context of healthcare? Because obviously, an ethical standpoint, I think we often hear people say it has to be in some sense transparent what the provider does. Is that or is that not the same thing as explainability? I'll turn it over to you, and then we'll turn it out to the audience.
I mean, I guess what I would just say is, the things that bother me are when you get examples of people who are like, well, what if someone's just using this AI system? But then when they go on to give you the rest of the case, it's not clear what it does and why they believe it does it. And then it's like, well, why would I trust the clinician then? And it's like, if I walk into your office and you're like, I want to give you this test. I'm like, great, what's it a test for? Well, you don't need to know. I'd be like, what are you talking about, right? Why should I believe the outcome of that test? I don't know. Then I'd be like, are you a doctor? Am I on camera? But that's how some of these AI conversations seem to go. And then what people are like, well, if you can't explain the model to me, then why would I do it? And it's like, have you had a rapid test? Most clinicians can't explain to you the method by which the rapid test gives you the result, right? And it's actually pretty complicated to figure out when you should believe the results of the rapid test. And so I'm like, what it takes for responsible clinical practice there, that's what AI should be like. And we should be as confident that the AI is accurate as we are. We validate clinically those rapid tests in a pretty rigorous way. They're not perfect, but we can measure what we're doing, and we should have those sorts of measures for AI in ways that I think are more credible than what internal validation gives us.
I agree, and I think transparency is incredibly important, and explainability is quite a small part of that. What I think about when I think about transparency is oftentimes I get calls from companies who are offering some AI solution, and it's not at all clear where they got their data from, how they train their data, the performance of their model on their data set, on the different characteristics. And they try and say things to me that they think I don't understand. The accuracy is 0.6 and that's fantastic. Explainability can be very useful. There are instances where seeing how a decision was made by an algorithm can be useful for deciding whether to go forward with the recommendations that it gives. But transparency really, and I think this is what the model cards are sort of moving towards, ought to be really comprehensive, to say everything about the data, to allow us to understand if there's biases entrenched in the data. And it need not necessarily be about, this is something we're talking about at the moment, should a patient have access to that kind of data card? I mean, it's probably unlikely that a patient who is in the future potentially having multiple predictions made about them is going to want to see these 50-page document data cards. But the point is that they should be available for every model that's produced. I think it's also important that they should be published prior to the model being developed. And it should be clearly delineated what standards are going to be acceptable. So slightly different, but both important.
Excellent. Thank you. All right, so we have 2 microphones in the room. If you get my attention up here, we'll direct the microphone your way. Plenty of time for questions about any part of the presentation. And then, okay, I see you at the back. Excellent.
So it seemed like a big issue that you guys pointed out was how research is being conducted in terms of implementing AI. And I was just wondering what your thoughts would be on how you could restructure this rush to publish, or just generating all these papers that are essentially worthless, like how would you approach restructuring that research?
Knock it all down and start again. No, it's incredibly difficult. The things that are important, I think, for good data science, good AI, like distributing credit for building a model among a massive team evenly, for like preparing data, doing the data science, writing the paper. It's just not how things work currently in academic medicine, where the prestige goes to the senior author and it's split, sort of bimodally split to the first and senior author. It's really tough in academic medicine. I don't know the solution. I know in companies, it's much easier. They can give an entire team equal credit for delivering on a tool or algorithm. I don't know if Alex has some ideas on how we can fix that.
I mean, I think part of this has to start. You can create a system, put it on archive, get lots of attention for it before it's peer reviewed. And then very often it will still be published in a journal without there being like uniform, clear standards for quality for your paper. So I think part of this, honestly, is that we're struggling to figure out how to incorporate machine learning, AI tools into medicine in a way that promotes actual science. And the publishing system is lagging behind because for a lot of people, just getting their paper out there, that's it, they're done, they got what they want. But for patients, you need not only for there to be a paper, but you need then for there to be a system that's developed from that, refined, implemented, lots of long, hard work. And, to the extent that academic medical centers reward publication, then the incentive system is probably wrong.
Don't be shy. There we go.
Hi, so I guess my question is, when I listen to a presentation like this, I always want to know, so I'm a nurse, and my question is always, what could I do to make a difference? I know this is all like a really big macro level issue, but I also know that I'm someone who puts data into an electronic health record that probably has been used for some sort of algorithm that I have no idea about. So has there been any talk, or what are your thoughts on the transparency for the people who are actually putting in that data, and how could that change some of these algorithms?
It's a really interesting comment and a very good question. Like, how can we build teams where everybody, from the person who inputs the data, from the people who build the models, deploy them, they're all kind of aligned? And I think there are numerous things you can do on your own. But it needs to be done in collaboration with a team who are kind of using this data. You can work with them to ensure that you're inputting and also other people are inputting in your department data in a standardized way. In surgery, there's been a big movement towards synoptic operation notes that kind of move to standardize the way people are making their notes about operations. And I guess one of the aspirational goals of doing that is that data will be much more usable in the future. So as a practical answer to that question, I think you can work with others who are entering similar data and trying to make sure you're entering it in a similar way, at least, that you have standards, because that will make a difference downstream, even if you can't sort of reach those people downstream. But the ideal thing to be would be to set up, an entire chain of people using this data within your institution.
So I think it's important that current generations of AI systems, there's a lot of people who have a lot of stake in the narrative of replacement, but I think it's very unlikely in healthcare anytime soon that you're going to see AI systems replacing people, and that to have effective healthcare systems, the people in those systems are going to have to be able to work with AI. And AIs have to be developed in ways that are usable by people. So Madeline Claire Illish is a social scientist who studied Sepsis Watch at Duke, their deployment of their sepsis detection algorithm. And it's really amazing. Like, they did all this model work, they did all this like really fancy AI work, and they started the model, and it's like, here we think Johnny's at risk for sepsis, and they'd get on the phone and they'd be like, hey, we're the AI people upstairs. We think Johnny's got sepsis. And they're like, what do you want me to do about it? Like they had to have nurses on the ward who liaise between that team and the rest of the ward in order to actually make a system that would function to try to help patients. And so I think the main thing you can do is if there's a rollout of something and the rhetoric is around like replacement, do what it takes to shift that to, wait a minute, like how is it that we're going to work with this system? Data gathering is another thing. Lots of people don't actually want to use AI systems because doing the extra steps that it would take to input the extra data is a tax on them, right? It benefits these guys, right? The model developers or whatever, right? But it's a tax on you. And so there has to be like very clear either change of incentive systems so that like the time I spend doing this, I get rewarded for. Or some other thing to make sure that there's coordination so that everybody is willing to actually do this. Otherwise, you'll get people that are like, yeah, sure, here, like I'll enter, like there, I entered your data, right? Like I gotta go do my thing.
Just to follow up on that. So one of the points that was unfortunately missing in one of my slides was that the AI systems that we have access to, they're supply side driven, right? They're models that are easy to build using electronic health record data. They create predictions that probably you don't care so much about. It's important to reduce ED admissions, but it's probably not the thing that you come to work trying to solve. One advantage of the mindset you kind of have is like, if you're entering data that captures something that's very important to you, then you can work with a model builder who can build you a model to solve the problems that you really care about. That's how our lab focuses. Like we look at smaller data sets that solve very particular problems. Perhaps like, should a woman have a mastectomy or a lumpectomy? And so if you're developing that data yourself and you have control over that, then perhaps there's more likelihood that someone will come along and help you build an algorithm that is really specific to the questions you want to answer. And I think that's probably the kind of grassroots way that the AI initiative should grow and really have impact.
Good. All right. So I saw a couple hands right in the middle. Okay. Yes. 1, 2, and 3. Okay. I've got you in order now.
Okay. I had a question about the bias that you talked about that we know is part of our systems or systematic bias. Are there models being developed for AI to identify biases that we may not see ourselves? And also, are we seeing that being successful? Is AI able to help us identify biases we're seeing instead of just having them accidentally baked in? Can we use AI to find those?
Yeah, I think absolutely. And again, that's one of the points I really wanted to drive home is that if you build a monitoring system that will, can screen for these things, it can look and see if there is differential treatment of different groups once you've developed and deployed your algorithm, then yeah, exactly, that would help you find these areas where, biases are kind of occurring. So it could actually, I think it's a great suggestion that you have, that it could actually be a tool or a means for kind of identifying where these things are happening. Because at first you see that your algorithm is performing differently, and that can set you on a kind of path to kind of understand where that data is wrong. And I think a key point that I wanted to talk about is that the more often you monitor, like if it's weekly or daily, then the more likely you are to catch these problems before they become a problem. So yeah.
So I would just say, I think bias is one of these terms that does so much work it's like AI itself. We were talking like, well, what is AI? Is it linear regression is AI? Large language models are AI? Like everything in between is AI? So it's sort of, there's a lot that counts as AI. Well, so too, bias now is a term. Like if you open a statistics textbook, bias means something very specific, right? Mm-hmm. But in AI, bias means like any way a system can go wrong pretty much. And so in that sense, it's become a less useful concept. And now data can be biased in many ways, some of which you can fix with data analytic tools, some of which you have to do new science to figure out, and some of which we need to improve the accessibility of our healthcare systems so that we get the data on the people who are not there because they're not in our health systems. And so in that sense, when people are like, well, couldn't we figure out a way to get like synthetic data? It's like, you're not solving the underlying problem, right? Like you could have a better model, but our underlying problem is we need to get a healthcare system that's equitably accessible by the diversity of the people in our communities that rely on those health systems. Then we'll have actual data on like what happens to them in our healthcare systems, and then we can refine it and make it work more effectively.
Okay, then I think we had the gentleman, in the white shirt, and then you're next.
Can you hear me? I'm a physician. I'm a pathologist, and Thursday I'm facing our breast cancer tumor board at my hospital, in which we'll have 6, 8, 10 new breast cancer cases that we talk about. The data points are juggled and considered, and we deal with things like tumor size, tumor grade, location of the tumor, and we have to make decisions like, is more surgery necessary? Additional lumpectomy, mastectomy. What about radiation therapy? Yes, no. What about endocrine therapy, such as aromatase inhibitor? What about cytotoxic chemotherapy? And with all these things, if so, how much? They're expert physicians. We have decades and decades of experience, but we still kind of do this by the seat of our pants. Is there any chance that AI might one day come along and say, just input the data, hit return, and you get an answer as what's best for the patient?
Yeah, I think absolutely. Models can do various parts of the things that you suggest there. I kind of envisage a future where you will have your board and the AI will perhaps be like another person in the room that you consult, right? It'll give you some ideas, and this is the point about explainability being quite important, that if it can suggest a route for treatment and give you some idea about how it came to that conclusion, then perhaps you can judge whether you want to kind of listen to that. But yeah, I think that's absolutely possible. And if the data are there, the models, the algorithms are also there to make that happen.
So, I mean, I'm not a futurist, right? As someone who will eventually has been and will be a patient again, I really want all these things to come to fruition. I think there are going to be some parts of them that's going to be easier than others, because some parts of them, there is some underlying, it's going to be easier to build a model of the underlying causal relationships. In other parts of this, I'm not sure, a lot of what you're doing in some cases is extrapolating from the evidence that we have on the very narrow populations of patients that we have evidence about to these patients who don't fit that same mold. And it's like, when we haven't run a drug in that patient population, I'm not sure there's a right way to do that. And so, AI or human or whatever. And, we're extremely complicated neural nets as well, far more complicated than any of the AIs that we deploy anywhere. And so, I'm not sure that I would need to see real evidence to trust sort of the model replacing the board, even though I think there can be ways of trying to regularize and try to, learn, because ultimately we want this to be much more like structural engineering, where you're like, given this tumor here, we just make up the thing for that very person, right? Customized treatment for that very person. But we're not there yet. And then until we are, I'm not sure there's a sort of a frontier of guessing, right? Extrapolating, interpolating. And I'm not sure how much of that frontier we can sort of do better at with machine learning. That's like an open question.
Exactly. And I think just to return again to interpretability and explainability, one thing that we've been working on that we're quite keen on at the moment is when producing a system like the one you described, the way in which we describe the interpretability of the system is we say, okay, in our data set, there are 300 people who are quite similar to this person you're looking at. And these are the different outcomes they had based on different treatments. And we feel like that is possibly one of the better ways to feed back information. We can show you how many people are in the data set, what actually happened to them, and how similar they are to the patient or the case kind of sitting in front of you.
Okay, I've got a couple of hands in the center. I'm sorry, you had your hand up for a while, yes? So it's still, you're next, and then I see you guys in the front here, and then I think off to the right.
Yeah, so I'm a nurse informaticist, so constantly in the EHR, trying to be both the nursing and the provider perspective. And so I think about the different AI tools that we have in our EHR. We have some that are very objective and some that are very subjective. And objective is easy in terms of, as you said, we discover our biases, we adjust the tool, we get all this research about the patients. But then I struggle with our subjective AI tools because while yes, I can educate people, it's really easy to make education we just need to teach them to do better and fix the data. But do we need to allow some bias in to allow the AI to compensate for that? We're just never going to achieve subjective perfection, that every nurse will document the same, that we're all putting in the same data.
I see. So to clarify, your question is, should we allow some differences in the way that you input data? Is that right? What you mean by subjective?
Yeah, I think it's like, I think everyone always assumes bias has a negative connotation, but would allowing some bias in the sense of compensating for that subjective differences actually assist?
Interesting.
Because otherwise the tool is contaminated. Like I can literally talk to two different units and one unit is working because they believe their documentation and their process, and then the other unit, it's absolutely failing because of how they perceive their population.
Can bias be good?
I mean, bias can be good because the world is, so this is part of the problem with bias. In a world where, so Google searches at least used to systematically underreport the proportion. If you sort of typed in CEO, many more images of men would appear than women, even though a higher percentage of women are CEOs than what's reflected in the images that were returned. So even though it's far from 50-50, I think it's about 30-70. The search results would return far out of proportion from that. So, but what do you want? Do you want it to return 30-70? So do you want it to be statistically unbiased because it's reporting to you the sort of proportions as they are right now? Or do you want to say, well, that just happens to be the way it is now because of the history that we have, which isn't always that great. So maybe what we want is for it to be more of like a 50-50 split, right? But now that would be statistically biased, right? Not accurate, but normatively, it might be what you want. And so in that sense, also, the fact that something is biased isn't always bad. If I have a thermometer and I know the bias, then I just can put a piece of tape on it, right? And be like, subtract 2 degrees, right? Like perfectly fine thermometer as long as I know the bias.
Good. Okay. On the left up front, and then Jonathan. Getting a little closer.
Thank you so much for being here. From my nascent understanding of AI and machine learning, I get the feeling that the real struggle with bias comes to head when we try to create models that are trained on this large sets of data and you deploy them to be ubiquitous in their functionality. Why can't we, or should we not develop models that are very specific? So maybe a health system in Pennsylvania that serves a predominantly rural and agricultural population works on their own model, works with their own model, compared to maybe like a big, UCLA, which is renowned hospital that works with their own model, that has their own conditions and so on.
I think honestly, you're exactly right. And it's really a paradigm shift in how we think. The papers that I publish a model and I talk about that model being the model, but I'm more and more growing to realize that it isn't the model. It's a demonstration that you can build a model to do this task using this particular input data. The reality is that, it should be a separate model wherever you use it. And wherever you use it, not only should it be a separate model, ideally trained on data as local as possible, but in 3 months' time, it should be a new model again because you're continuously retraining it. And this is something that I think you're picking it up. You say your knowledge is nascent, but it's not really becoming represented in the literature how best to do this quite yet. But I think you're exactly right, and that is what we need.
So I don't know. I'll just say a couple of things because I think you're on to something that I think about from time to time, and I'm just going to say some thoughts around it. Because on the one hand, like, what would you say if I sat here and I said, listen, I'm not going to make drugs that work for everybody. I'm just going to make more drugs that like work for the person, or diagnostic tests that works for the people of rural Michigan, right? But don't take it to California. It's probably not going to work there, right? You'd be like, is it really diagnosing the underlying thing? Like, if it only works here, what's so special about here that it only works here, right? And now my engineer friends will be like, there's so much like about specific local practice, specific local workflow, like, and also like we're projecting out. It's almost like, when in the stock market, you want to have your server like right at the stock market so there's less latency, right? It's like I want to build my model as close to the new data set as possible because I'm really only projecting out just a little bit in time, right? And it's like, okay, that's a very like engineering model of this, right? You're not like, that's not the science model. You're not saying like, I'm learning something about this disease process or, and so I think that's why now it matters. Like if we're talking about making sure that you have the right things stocked in your, ER, and I agree, a lot of the best places we're going to see the biggest return on investment for AI are in the business operating parts of healthcare as a business instead of the client-facing part. But there, I think, like when you might be optimizing different things in the emergency room, right? But like it's the same underlying problem. And so like that then it's less like the engineering and more like the science. So I see where it comes from. And sometimes I have sympathy with it, but then other times I'm like, we should stick, with the more ambitious prospect of trying to develop models that are robust, and robustness would be, you could use them in lots of different places. The other thing I worry about is that it's going to be a fact that rural hospitals aren't going to have sophisticated data science teams that are going to be building models for them. And so you don't want to further now sort of like, there's like world-class medicine gets practiced in a few places and everybody else, is left behind.
I think we are moving towards a point where, to Alex's point, we're going to be able to collaborate more widely on data. So it isn't just a model that I train in my hospital that you use in your hospital. It's like a model that's trained on 80% of people in the US, and perhaps the people in this data sharing collaboration could be set up in such a way that the model is not going to be brittle and it is going to work kind of anywhere. But I think really the important thing is that you're creating a task competency, like the ability to solve a problem. And whatever system you build to solve that problem, whether it's a simple linear regression, a super complex neural network or whatever, as long as you can demonstrate that it's working day by day by day and it's not, then I think the way that you get there is like less important.
Thanks for those wonderful talks. I had a question kind of reaching back to the question about the tumor board. Rather than inputs and learning what kind of data we should be pulling, I'm curious about kind of the outputs. So when should we start to listen to these AI models more than the experienced physician? Will there be a time when, the AI system, definitely knows better than the person with 10 years of experience? Currently, at least with the presentation about sepsis, there seems to be this disproportionate, like the human knows better. The system says sepsis is increasing, but I'm going to turn that off because I know it's wrong. Will they go in the other direction?
So in that case, we knew it was wrong in the same, just because we knew that the world had changed in a way we'd never trained the AI, right? So this is one of the reasons why I think that we need to get beyond internal validation and do things like silent trials of AI systems. Because, so what a silent trial would be is, we would have something like the tumor board, but then we would have our model running alongside of it. And our model would be making recommendations at the same time, but the tumor board wouldn't see them. And then we could look and we could see, well, look, what were the recommendations of the model? What were the recommendations of the tumor board? Now, for long, farther out things, validating the, sort of clinical endpoints is going to be more difficult. But for things that resolve where you have meaningful clinical markers more quickly, then you'd actually be able to look at and see, look, does our system perform better? And if it does, then you might be in a situation now where you have something like aspirin, where you're like, our model's performing better than the people on the tumor board. Why? Now we want to do science to try to figure out what it is that the model is using conditioning on in order to have this, get this performance, right? Because when we've done some of that, I shouldn't say we, when other people have done some of that stuff, and looked at some of these models, they've encountered really interesting things, like models that work very well at prognosticating who's going to die on the ward, But one of the data points that they used was that that person got visited by the chaplain. So if you reverse the flow now, and it's like this model is telling the chaplain where to go, right? Its probative value is going to plummet. So, yeah.
I think you raise an interesting question, like when do you start paying attention to an AI model? And I would ask the gentleman who asked the question about his tumor board, if a new doctor came to your board who had just got a great medical degree and they disagreed with you on the first day, would you change all your minds and listen to them? Probably not, right? You would learn to understand that doctor's opinion over a period of time. And after years of working with them, you begin to, learn where they're good, learn where they're bad, and trust their judgment in some cases and perhaps be more cautious in others. And I think, honestly, algorithms will form a similar function. Actually, we're doing some exciting work right now around foundation models, like task, general agents, and how we can use things like psychometrics, my other kind of academic interest, to give insight into the way they might behave in these sort of teams, above and beyond what was their score on the medical licensing exam, right? Which again, we don't do for our colleagues, right? We don't just hire doctors because they have a particular score in the MLE. We get recommendation letters. We ask their colleague. We might phone their chief and ask about them. So we want to start doing the similar things for these AI systems, I think.
I like the idea of interviewing the interview with the AI on its way in. Now, did you still have a question? You had your hand up before, and then I see another back there. So yeah, it's you. Yep. Oh, I'm sorry.
I got this one. So you guys touched on this a little bit just a second ago, but I'm curious about how we could invert the model of having data that we already know, training a system to then go back and retrospectively predict an outcome based on that data, to having sort of a forward-looking intuition and using AI in a prospective sense to test that intuition by either gathering data or validating hypotheses that we might not pick out.
So, this is what everybody who's using whatever their fanciest model is in drug development is trying to do. Drug development is a place where you're, by definition, trying to create something that didn't exist before. But of course, there's a finite number of pieces that go into everything. So then if you're like a Bayesian, I don't know if that's outside of Pittsburgh, I don't know what but then you might be like, well, it's all some sort of hierarchical model of what do these compounds do if I put them together in this new way? I've never seen this thing before, but of course I can make some predictions about what I'm likely to see. And of course, you can make predictions, that's fine, they're probably wrong. And so the world will tell you whether they're right or not. And so what we effectively have now is all these people with deep pockets and who can get people with deep pockets to invest. They're doing just this. They're creating models. They're trying to predict what's going to happen in the real future, not where it's permutations of what we've seen before, like in Go or chess, but where we've never seen this before. So what's likely to happen? And then models that work. Then it'd be like, well, let's figure out what can we look, we can actually do science from that. What is it what's going to work, right? The interesting thing is, drug development is incredibly complex. And so you'll hear people talk about AlphaFold has revolutionized protein folding. True, absolutely true. Would not want to take anything away from those people. But that wasn't the bottleneck to getting new drugs. And you'll read a new paper all the time. It's like, our model came up with, 250 new drug targets. It's like, that's wonderful. We don't have a shortage of drug targets. We have a shortage of things that work. And so and everybody believes their model. Otherwise, they wouldn't be investing hundreds of millions and billions of dollars into their models. And when you start to see success rates really increasing, then it'll be like, wow, we're getting closer to the engineering model than we are now. I just think it's incredibly hard. And the people that, I have former students who work in this field and I'm like, isn't it like this? And, I said, I said to one of my students once, biology is kind of like you put something into a box, right? Drug development's like you put something in a box and you look to see what's coming out the other side. And she laughed at me. She works for a big firm in New York City doing very complex machine learning on genetic stuff. And she's like, it's like you put something into the box and something comes out in Tokyo.
That's great.
Okay, I think we've got two more, and we've got time for two more. So the gentleman over here, and then you still had your hand up. Yeah. So.
Thank you. Just a question. Now that you brought the concept of the chaplain in the care model, I was wondering if there are any care models actually in the AI being developed to respond to the concept of, or introducing, the concept of belief in the models. As you mentioned, obviously, about the example of skin, like on bias in terms of, how do you apply the model in terms of that area? Belief is a little bit more complex, I believe, in terms of, the many different cultures and even, individuals. How do we respect that concept in the application of the, a model that can actually serve for the care of people?
I think that's a great question. It was something actually we used to think about a lot, perhaps in like 2015 or 2016. So whenever we built models, some of them ML, some otherwise, and like we put them online and we asked patients to complete them, we made a prediction, and we fed that prediction. We always wanted to capture the patient's belief. Does this sound right to you? Right, and we get that feedback, and the idea, although that kind of never materialized because I moved to the US and had to give that research funding back, was that we would use that kind of belief to kind of improve the model in the future. And I think 5 or 6, 7 years ago, that's how we thought machine learning would work. We would create predictions, we get people to feedback on whether they were good or not, and then we would continuously retrain by using that information. What was really interesting was that I was predicting people's quality of life, and almost everyone believes their quality of life was better than normal, right? So this what Lake Wobegon effect. So that was one of the things we had to take into account in our models, that people don't like to hear that their quality of life is average, even though that's by definition not very bad. But yeah, I think it's also something that we should bring into like modern clinical AI, and something we can also use, right? Does this model seem right to you? Do you have belief in it?
So I think that there are a lot of places where we need to understand the limits of AI, and where patient preference, legitimate patient preference, is what should rule the day rather than any scientific question. So for instance, the decision about what procedure you're going to have if you have breast cancer or you have genetic predisposition to breast cancer is a very personal decision. It should be informed by scientific evidence about recurrence and survivability, but then it should also be informed by your beliefs about your body, what your tolerance for risks are, other things like that. And no AI model can do that kind of work for you. And we don't want to deprive women of the ability to make those decisions by hiding those things inside an AI model where we say, this magical box has said that this is what's best for you. So that'd be one thing. Another thing is we have to make decisions for people who don't tell us what they want, and then they become incompetent. And this is another area where usually what we do then is we say, well, we go to your loved ones and we're like, what would they have wanted? This sort of subjective decision make, substituted judgment, what would they have wanted? And now if you take living couples and you sort of put them in separate rooms, and you're like, what would your partner want in these other things? They're wildly wrong, right? And then there are people out there who want to say, so what we should do is we should build a model of you. And we should be like, well, what would someone like you want? Okay, this is what machine learning does. So like you in what way, right? What's your gender? Does that apply to you? Where are you on that thing? What's your sex? What's your age? What's your marital status or not or whatever? And then it's going to find people in the population like you, and then what they would want. That's a statistical way to try to do this. And, to me, it's less a question there. You could ask the question, which one of these is more likely to be accurate, where the idea is predict what you would really want. And then the other thing is, what kind of social practice do we want in terms of making decisions for our loved ones? And there, I think appealing to some statistical model that reduces you to a stereotype might not be the kind of social practice that we want when it comes to making these things, even if your loved ones are very likely to sort of get it wrong from that actuarial standpoint. So those are two cases where I feel like there's a lot that's very human in medicine that we can't just sort of put into the model. The models should be left to do the scientific work.
All right, I think we've got time for just one more. And yes, you've got your hand up. Yeah, so, yeah.
Sorry, where?
Yeah, right there where you see the laser on the floor. Jeff, that's it. Okay.
Hi. A while ago, I read about a instance. So Cigna Insurance, they piloted like an AI program, and basically they had some biases or mishaps, but it stood out to me because there was a client that they had denied like an insurance claim because they needed mifepristone, which is also like the abortion pill, but they needed it for like Cushing's syndrome. So I guess my question would be like, within your field, has there been more discussion about like concerns for compassion, or you mentioned competence over like intelligence regarding like AI systems being installed and programmed for different realms in healthcare?
I honestly think it's a tough place to implement a model where you're using like an algorithmic thing to decide whether somebody gets a particular drug or not. It's not the sort of place that I like to build models. I like to build models in gaps in human competence where like we don't really know what's going to happen to a surgical candidate 5 years in the future. So maybe a model can kind of help us fill that in. And if we make a mistake, it's not so bad because we didn't know anyway, right? And I think in this area that you talk about, it's really tough. How we deal, and there's going to be mistakes, right? No model is perfect, no model is deterministic. Like, how do we, deal with those mistakes in the future? I think we need people like Alex to tell us.
I'll tell you exactly.
Yeah. Thank you.
So, I mean, the thing I'd add to that is I think there needs to be much more accountability among people who are not usually called out for in ethics. These would be very senior corporate leaders, about taking responsibility for the way that risk gets distributed by their algorithms. So because most of what I say is negative, I'm an ethicist, I'll give you I'll end on a really positive note. So I believe the insurance company was Geico, but I could be wrong about that. But they implemented a model, and I believe it's one of the first models that will sort of automated approval of insurance claims. So a human doesn't even see it. The patient enters it, gets approved. And I say approved because they designed the system to only approve models. These are going to be all claims where there's no proof of loss. So it's going to be like, you're entitled to a certain number of visits, see your clinician and you went, and so you want that covered, and the thing will be like, yes, that's fine. And so the idea was, they would accept the risk because sometimes it's going to approve things that it shouldn't approve, but it can't automatically deny anybody. Anything that looks weird goes to a human, and so the human reviews it. And then their bet was the scale of volume that we get at using this to approve these very routine claims will free up our humans to do other things, and we'll accept the risk if the system is wrong. That's very different from other things that you read where people are like, yeah, we implemented this AI system, and guess what? It denied all these claims, and guess who was the beneficiary of those denials, right? We were, or our state was, when it denied a whole bunch of claims of people who were filing for assistance, and the AI model said fraud, 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 and then it went to court, and they were like, this turned out to be bad work. So I think the idea of like, being willing to sort of say, I'm going to build a model where I'll accept the risk, and I believe in my model well enough that I'll do that. That would change the incentives around, instead of being like, oh, if my model doesn't work, I stand to make a windfall. Those are bad incentives.
Good. All right. So we're basically at the end of our programming. I think we had a really interesting discussion. We're really still, as history goes, I think very early in the development of this issue, of its ethics, of how it's working. Who knows what the conversation will be in 5 years? Are you guys going to be free, maybe to come back and see if these questions have been answered? But thank you very much, and let's thank our guests for their presentation tonight. And just as three quick reminders, so first, also, again, we'd like to thank our sponsors, of course, Corewell Health and Trinity Health.
As you're heading out, remember that if you are interested in obtaining CE credits, be sure to stop at the table on the way out. There's information for doing that there. And also, the next DeVos Ethics Colloquy is going to be, on October 14th. So mark your calendars. Okay, October 14th, 2024. Information TBA. So thank you again, everyone, for being here tonight. Thank our guests. Have a good evening. Thank you.